Well, hello, everyone. If we've done this right, we should be live, and I want to welcome everyone today. I'm Kurt Chase. I'm a partner at the law firm of Husch Blackwell, and I lead our Healthcare, Life Sciences, and Education business unit. We wanted to welcome you to our second webinar in an 8-part series on health law and innovation. I'll give you a list of this is the second one. I'll give you the list of the other 6 that are coming up here in a moment in case you find any other topics that interest you and you'd like to register for. Before we get started today, I wanted to cover a couple of housekeeping items. At the bottom of your console, there should be a number of application icons that you can use during the program. If you have any questions during the webcast, submit them in the question box and we'll try to answer those questions. If we run out of time or the questions result in something that needs a much more detailed answer, we'll follow up by email after the presentation. There is a PDF of the presentation available in the resources folder on the site, and the program is approved for continuing legal education hours. And to report those hours, if you click the CEU icon at the bottom of the screen, you'll get a certificate of attendance, including the course numbers and so forth. Those will be emailed to you tomorrow, along with an actual recording of the webcast if you want to watch it later or share it with anyone. And then toward the end of the program, we'd really appreciate it if you completed a survey. This helps us in feedback to plan future programs. One of the things that we always like to hear about are the types of things that you would like to hear more about, specific topics and so forth. So with that, a couple of other notes. Some of my colleagues actually went into their offices today. I'm actually working from my home office, so I will apologize in advance for any UPS personnel that ring the doorbell, dogs barking, or other types of noises as we are in this work from home environment. So hopefully none of that will happen, but you know, we're getting used to those things. The one thing I can guarantee you is that I'm not going to be Chris Wallace or Susan Page and have to interrupt our presenters today and tell them they have 2 minutes uninterrupted time with no interruptions and responses. And I can also guarantee you they're not going to call each other names and interrupt each other. You know, I cannot guarantee, however, that a mysterious fly might land on my head or something and distract you. If you watched the debate last night, you know what I'm referring to. So with that, I wanted to quickly note these are the next 6 sessions that we have coming up. We're doing one a week. The last one is strategically placed after the election and is intended to be a projection of a legislative outlook. Should be interesting no matter which way the election goes. But the other ones are more specific topics. So that's the housekeeping items. With that, we're going to jump right in and get started. So today's session is developing strategies around hospital and physician integration, and we're excited to talk about this. We're going to, part of it is going to be referencing alignment models that are changing, in our opinions, post-COVID-19 or maybe during COVID-19, I guess. We're not post that yet. The point of today is really intended to create a dialogue and a discussion around what our panelists are seeing coming in the next 12 to 24 months. It's not a deep dive into one particular model or another, or to try to present in depth some particular model. If there are interests in particular topics that the panelists talk about today, though, we would encourage you to put that in the survey notes or in the comments in the chat, and if there's enough interest, we'll be happy to do a separate webinar on a particular topic. So with that, let me introduce our panelists. I've introduced myself. Along with me is Bruce Arnold. Bruce is a partner in our Healthcare, Life Sciences, and Education business unit at Husch Blackwell. He's in our Milwaukee office. Bruce counsels clients on all aspects of healthcare matters, regulatory, and a lot of transactional and integration work, specifically including hospital physician strategic alignment. payer agreements, joint ventures, and the like. Bruce also has a unique experience level in the area of insolvency proceedings and restructuring in a number of aspects of the healthcare industry. Also, as our guest panelists today, we're really pleased to welcome two folks from the consulting world that we work with and think very highly of. The first one is Anthony Long. Anthony is a partner at Pinnacle Healthcare Consulting. He has more than 25 years of executive leadership experience. He oversees the strategy and operations division, consulting division at Pinnacle, and has a lot of expertise in strategic affiliations, mergers and acquisitions, and service line development planning. Cordell Mack is also joining us. Cordell is a partner at Healthcare Futures with over 19 years of healthcare management experience and specializes in helping provider clients with strategic and financial needs, specifically around issues on capacity, capital availability, strategic planning, and M&A. So we've got a really great panel today. You're going to hear less of me talking and more of them, which is the point of being the moderator. But let me highlight kind of where we're going to go. So today's session, we're going to touch on 5 topics. Depending on the amount of time we have, we'll certainly try to hit all 5 of them. We thought we'd kind of level set and talk about what the panelists are seeing in the current environment and what's happening in the environment, what some competitive models are that are emerging. Some of them have been around for a while, but are gaining a lot of traction. And competitive, we mean to the traditional hospital physician integration model. And then what are hospitals' responses to that, to that competition? We'll touch a bit on the changing economics of various types of affiliations and what that looks like, particularly in light of some of the recent activity with COVID. And then how COVID is changing the care models and specifically how those care models are going to affect strategic alignment and affiliation between hospitals and physicians. And then we're going to ask the panelists to give us some final thoughts on these intangibles, the things that in their experience they've seen make affiliations and integrations work and where we need to be focusing some of our attention. So with that, let me start with a question to all of the panelists, and that is, what are you experiencing in the hospital physician integration activity today, whether it be deals? Has that activity been impacted by COVID in some ways? Has it slowed down? Has it increased? Just kind of what trends are you seeing?
Hey, Kurt, this is Cordell, just by voice for those participating. Thanks for the opportunity. I'll go first. I think as a general statement, we've seen a rebound over the last 60 to 75 days, Kurt. Certainly as we entered into the initial phase of the pandemic in March and April, there was just all the preparedness work, and with the shutdown of all the elective activity, we weren't seeing either a lot of just work that was occurring inside of health systems around optimization efforts as it pertains to medical groups, as well as any affiliations with independent practices. As people have learned to live inside of this environment, certainly the last 60 days, volumes have started to come back relative to just deals and transactions. I think there's probably 2 different types, right? I think there's certainly a listing of independent practices that, as they've tried to couple this latest environmental threat with kind of prior iterations of just economics and migrations to EMRs and et cetera. Not to say that they're necessarily distressed, but they have certainly reached out to their health system or their hospital counterpart, and they've just said, hey, is there a better way of doing this? The health systems have been able to almost somewhat stratify and prioritize some of those deals a little bit better maybe than what they have in the past. And then I also think that there's been, a series of transactions that are beginning to emerge even inside of health systems and hospitals as they've, kind of taken a step back and said, hey, how did our compensation systems, did those kind of, manage pretty well throughout this event? Do we need to think about something a little bit different? Do we have some additional optimization, opportunities that may be, kind of directly in front of us? So overall, it's been a rebound, and I think we're seeing deal levels that are pretty close to maybe where they were pre-COVID right now.
Okay.
Yeah, and I would, Kurt, it's Anthony. I mean, I would echo what Cordell said. We're seeing a lot of activity, I think, between distressed practices, but not just those. I mean, I think that there's also hospitals that spend so much time in COVID preparations and responses that you are seeing a lot of activity happen at a very quick pace. And so, I think whether that's because of the upcoming election, whether that's because of end of year financials, whether that's because of budgets, there certainly is a lot of activity. The other thing we're seeing are just different types of arrangements. So not just your traditional hospital physician arrangements, but others that we'll talk about throughout the presentation today, and starting to see AMCs and community hospitals having conversations, starting to see additional entries into the market. So definitely a lot of activity and a lot of just quick turnaround type of activities as well.
Kurt, from my perspective, I'd start by saying we're spending a lot of time with the likes of people like David White from Anthony's firm at Pinnacle. Some of the classic hospital physician alignment models that we and you have worked on have experienced what I might call the pause button, particularly in those instances where the arrangement is especially sensitive to fair market value and commercial reasonableness kind of metrics, hence my reference to David at Pinnacle. We've seen some pretty creative stuff taking advantage of the COVID waivers. Thank you, CMS, for at least during the duration of the public health emergency, giving folks a little more runway. A good example is I've seen hospitals lending money to physicians, particularly anesthesiologists, to offset their lost income from the cancellation of elective procedures. And not to be too awkward by saying this, we can't lose sight of the fact that 42 hospitals have either closed or have gone into bankruptcy this year. And in the years of doing sort of bankruptcy in the healthcare arena, I've never seen more deals done in the bankruptcy court as opposed to it's sort of the boardroom. A very interesting development, and it's clearly tied to COVID.
Very good. I think those are all great observations, and will guide some of the conversation as we move forward today. One of the things that we want to do is we've got 3 poll questions that we're going to have you all answer, if you're on your computer. And the first one is here on the screen. What type of healthcare provider do you most affiliate with? And the choices are a hospital or health system, medical group integrated with a hospital or health system, an independent medical group, or other. And I know we have a wide variety of folks on the webinar today, but just trying to get a sense of the attendees. So if you don't mind clicking one of those, and we'll have 3 different poll questions that we're going to put up. So I'll give everybody a quick second to answer. All right. Hopefully that was enough time. So pretty interesting spread. Okay. So there's, wow, 33% other. So that's great. Quite a few independent groups, and then a lot that are with the hospital side. So that'll be helpful as we move forward with the conversation today. The second poll question we wanted to put out there is, has COVID-19 affected your approach to future integration strategies? Definitely, maybe, but I'm waiting to see, not really sure yet, and then no. All right. Don't want to rush everybody, but hopefully you can find the buttons to click. I'm going to move on. Kind of what I expected. If you put this on its side, it'd be a nice bell curve. It's I think that the 70% that said kind of not really sure yet is very consistent with what a lot of us have been seeing, but there certainly have been some changes that have occurred. The last question that we have is not one in particular, maybe all of them, but we wanted to just pick the one that's the most relevant. So what has been the biggest change to your care model during COVID-19? Increased telehealth, changes to productivity and compensation models, personnel or staffing changes, or finally kind of the cost issues with managing with decreased volumes and increased costs around PPP and other things. My guess is a lot of you could answer by clicking every box. I don't think the function allows that, so pick the one that's most relevant, and I'll be very interested to see which one this is up with. Okay. Also pretty good split. Telehealth being a dominant one. Well, for those of you that answered telehealth, you probably saw next week's webinar, which I'm also moderating, is going to be on virtual health. So 43% of you may want to sign up for that session as well. We've got some really great panelists lined up for that one. We will touch on telehealth a bit today, but we're not going to steal the thunder of the group next week, certainly. But we had a suspicion that one might have a pretty high response rate. Okay, so let's jump into the next part of the presentation. So we talked about kind of where we are now and kind of what we're seeing, and I thought about getting a magic 8-ball and shaking it and seeing what comes up, because some days that's what I feel like. It's a very fuzzy crystal ball that we're all looking into. But to level set, it's where have we been? And this is probably a hard slide to read on your screen. I don't know if you can expand it or not, but it's certainly in the materials. Most of you have seen a slide like this in the past, but basically, if you look in the lower left, it's lower integration, low risk, low return of medical directorships, stipends, management contracts, all the way up to if you're in a location that can and basically integrate in the hospital, with a lot of things in between here that you and I and all of us have seen many of, co-managements and PSAs and that sort of thing. These are models that, quite frankly, hospitals and physicians, in my experience, gravitate to, in part because it's what they know, it's what they've done, and whether they work or not in every situation, it's familiarity. What we want to next focus on is kind of what's coming and what should be coming, and I kind of give it away a little bit in the slide, but what are those competitive models that are out there? Where is the industry going? And some of these aren't going to surprise you because they've been around for a bit, but we're seeing a huge uptick on some of these. And I'm going to ask our panelists to just comment on one or two topics in this area, kind of what they're seeing. And while they talk, I'm going to put up a slide, and this was courtesy of the advisory board. And it's a slide that shows, it's focused more on the health plans, but it's not just health plans. You'll see that there's a lot of activity going on around the country that are not hospital physician integration. So Anthony, let's start with you. What do you see as these competitive models and kind of where are things going in your opinion?
Yeah, so certainly venture capital and private equity is making a big play in healthcare. There's a lot of funds, a lot of available dollars just to impact and address groups in different specialties. We are seeing quite a bit of activity in maybe some of the more traditional areas: behavioral health, anesthesia, primary care, dermatology, dental, all areas that are certainly getting a lot of attention, and multiples certainly being driven up in that respect as well. I think as we kind of move around the country, there's certainly, it's one thing to compete against who local hospital in town or in the region, but some of the PE firms certainly are making it interesting, and obviously some of their the regulations that surround those firms, some of their approaches are maybe more aggressive than what we see in kind of traditional hospital-physician relationships. And then I think there's been expansion of the specialties being considered in that space as well. So, obviously some big names around, emergency medicine and hospitalist and radiology that's played out over the last year or two, but continue to see increased activity in this space.
Cordell, thoughts?
Yeah, maybe one comment to just piggyback on Anthony. I think it's, the whole experiment about physician groups and private equity, 5-6 years ago was pretty interesting, because I think there was this question about, as we kind of maybe cash out some older partners that may be inside of a practice, what's going to really happen to those younger partners as they come into that model? And are we going to see this as a kind of a single cycle and then, some dissipation of the model over time? But what's been a little bit fascinating is that, we've seen some groups go through now almost their second recap. And through that second recap, the model seems to be, what I would have predicted 5 years ago, the model today is a lot more sustainable than what I would have predicted 5 years ago. So I think the staying power behind private equity inside of, medical groups is something that we're just going to all have to kind of contend with. And it's a question for health systems about kind of overall competitiveness. And if not private equity, what can we do, as a hospital or as a health system as we kind of integrate our medical group? I think there's your other slide talked about the payer side of this, Kurt, and that's an interesting question, right? So in today's world, we don't have a large percentage of doctors that are employed by, a payer or by an insurer. It's certainly less than probably 5% of total physicians that are out there. And you kind of take a step back and you ask yourself, well, why are payers kind of getting in the lanes of where providers have traditionally sat? And certainly there's a side of it that says, hey, provider, you maybe haven't done as well as you otherwise could have, and so we want to get into that business and we're going to pressure you to be better, right? We're just going to simply demonstrate that we can deliver better outcomes, we can deliver better quality, and we're going to put some pressure on you to try to step up the game. And then there's also the more altruistic aspect of saying that, hey, we have an economic question in certain populations as insurers that we're responsible for. And, we really need to kind of control that channel with providers to be able to make sure that we meet, kind of our costs and our quality, target. And so you certainly have, the Optums, and I know Bruce is going to comment a little bit on Optum as we kind of move through this. So you certainly have these, kind of large scale, Optum-related strategies. But the thing for us that really started to stand out is, probably in the last 3 years, when the Blues really started to get involved in various states, it sent a little bit of a different message, because that message became a bit more customized, relative to, the opportunity that may exist in Florida, where the Blues offers, employment opportunities for physicians, in New Jersey, where the Blues offers employment opportunities for physicians. We hail from Minnesota. Blue Cross Blue Shield in Minnesota is in partnership with North Memorial. They have a joint venture. They have a joint venture medical group that, North Memorial has been able to unload, significant amount of practice losses to the Blues. And so I think the hope was that at some point we would see providers and payers kind of stay inside of their lanes. That's just getting more and more blurred. We think it's going to continue to get more and more blurred. I think the call to action for, and looking at your, kind of prior participant panel of, health systems with integrated medical groups, I think the call to action a little bit is, do we have to accelerate? Is the pace of change that we're currently on as providers, are we meeting really kind of the market need? And, if we can't meet that need in a way in which, consumers are desired in terms of outcomes, we're seeing some of these niche providers, we're seeing insurers that are just going to step in and kind of fill it, on our behalf. So, I mean, the call to action, we'll talk a little bit more about comp, we'll talk a little bit more about care models as we go through this. But I think on the payer side, people should take a step back as they evaluate their community and realize that in instances, there's a little bit of a referendum on the really kind of the pace of change that we're driving as providers.
Bruce, I'll give you a chance to jump in as well.
Just a couple of quick comments, and I'd like to reference the lanes. I suppose you could also say disruptors. So with thanks to our friends at the advisory board for letting us use that slide, what really strikes me, Kurt, is the flurry of primary care investments by legacy pharmacy entities, especially CVS with their so-called health hubs and Walgreens with all the centers they've opened with Humana, and Optum Care. It's not lost on anyone on this call that Optum Care now serves 18 million consumers in 44 states with something in the range of 52,000 aligned physicians. It is something that the providers, both hospitals and physicians, need to pay attention to, because it's another way, it's another channel. Thank you, Cordell, for the way that care is being provided here in the context of one of the subsidiaries of United Health Group.
Yeah, and it's interesting. So the title of the presentation today is around hospital physician integration, and so we're looking at these as you put it, Bruce, as disruptors or competition in the marketplace that many hospitals didn't exist. If you're on the physician side of the equation, you might view it as more of additional options available to you. And, we have a lot of participants on both the physician and the hospital side today. So, your perspective is probably different depending on which of those seats you sit in. The one thing that we hear a lot from our hospital clients is, how do we compete with private equity? How do we compete with the payers? Because we have these pesky Stark and anti-kickback laws that really limit us, and that are at least appear to be less applicable to non-hospitals and payers and private equity. It's interesting. I sat in on the webinar that the American Health Lawyers put on last week on fraud and abuse, and there was a whole session actually that included a DOJ attorney and I believe an OIG attorney as well, on their increased focus on fraud and abuse issues in private equity of healthcare. So, it's I think we're going to continue as these areas expand. The investigators tend to follow the money, and I think we're going to see an increased activity in some of those areas as well. Well, let's move to the next slide, which is how will health systems respond, and this is by no means an exhaustive list, and we're not going to cover each of these. That's not the point. It's just to give you some ideas. Some of these have been around for a long time. Some of them are kind of new areas that a lot of our health systems and some physician groups as well are looking very closely at in terms of, well, if we want to have an integration strategy, what does that look like? So I guess, Anthony, let's start with you again. What models or ideas should hospitals and physician groups be considering if they want to have an integration strategy kind of on a go-forward basis, and what would you recommend, some of the things they think about and focus on that are either on this list or in addition to?
Yeah, well, thanks, Kurt. I'll certainly cover a couple areas. So, I think that the whole risk-based contracting considerations is an area that we see a wide variety of expertise and a wide variety of where hospitals sit on the spectrum. And I think we have a lot of groups, a lot of physicians that will ask for, hey, if you're going to employ me, that must mean that you're going to make more money off of me. And then we get into the next conversation is, I can't share technical revenue, and I can't pay you for bringing business, and all the legal considerations that get involved. And yet, I think as we think about that risk-based approach, I think both knowledge about that space and also looking at models and trying to determine how do we move away just from a production and productivity conversation, but to a population discussion and a population health value-based environment. And those words are thrown out a lot in our world and Cordell's world. But, I think that the more we can appreciate and understand about how those risk models work, and I think, CMS has, we'll talk about this as we go through. I mean, they're continuing to promote different strategies, different models. Certainly the COVID year has allowed for a little bit of, slowing the glide, so to speak, as it relates specifically around those models. But there's still a lot of lessons to be learned, both in our, the early years of ACE, bundled payments, and, some got that right, and others, learned some mistakes. And, I think as we continue through, it certainly is an area to be aware of and certainly to expand on. The other area that we're starting to see some movement, and it's kind of interesting because we're seeing kind of movement in opposite directions. One, which is we have health systems that are saying, hey, how do I integrate, how do I involve my employed physicians now in joint venture activities, ASPs and other types of models, and others that are saying, hey, you know what, we're going to move completely in the opposite direction. And so, I think to be competitive, health systems, and I'm going to use a word which we don't like to use around attorneys, but, I think we need to talk about creativities and coming up with solutions that are outside the box. It's obviously there's still the regulatory and compliance component of that, but, an area that we continue to push and say, hey, let's not just talk about, what the Sullivan and Cotter survey says. Let's talk about other activities beyond production. Let's talk about how we can, look at some other approaches. So again, a lot of things to consider certainly, but just some of the areas. And then gain sharing, I think, is another area that is, certainly popped back up in discussions, much more so over the last, I'd say, 12 to 24 months than we were seeing before. So just some of the ideas.
Cordell, let me kick it over to you then next.
Yeah, thank you. I agree a lot with what Anthony said. I'll take the integrated health system perspective and talk a little bit about medical groups. And we all know the second that we employ physicians, there are several things that have changed historically. We've taken ancillary services, we pull them out of the physician organization, we put them over into an HOPD environment, and we essentially strip that revenue stream out of the physician practice. We've taken a compensation arrangement for doctors and for advanced practice professionals, and we've probably moved that to something that's more of a surrogate-based measure around work RVUs or productivity or something that doesn't have kind of an underlying level of economic reality to it. We've at the health system level, we've entered into various, pay for performance opportunities or shared savings opportunities, with peer relationships or with employers, et cetera. It's been really difficult to get those revenues essentially kind of back over to the medical group and into, really into the caregivers that's been associated. And so, unfortunately, we've, for those of us that are on the call or on the webinar that have, been in this industry for 20 years, it feels like this is a little bit of a cyclical question whereby there's attraction to integrate, and then we get the realities of some of the economics challenge us, and then we go in a different direction, then we come back to it all over again. And so we feel like right now there's, a lot of health systems have acquired a significant number of physician assets, and really what they are is assets. And the way in which they're now thinking about trying to optimize those assets is tending to be a little bit different. And so I see on your screen, you talk about the group practice subsidiary like models. Well, I mean, the idea the idea functionally behind what we're seeing on the employed integrated side right now is trying to drive some economics and shared economics kind of back into the relationship, such that the physicians have some greater skin in the game that's associated with, payer mix, associated with shared savings opportunities, associated with ancillary services that may come back in, their effective use of overhead or MAs or RNs. And so, the idea behind it right now is that, health systems, hospitals, trustees of organizations, they're all very interested in trying to define a level of sustainability and getting agreement on what a level of sustainability is in terms of an economic investment. And so we're seeing, I think, kind of a re-pivoting back to models that just become more economic based. I agree with Anthony. We have a wealth of information about market compatibility through survey instruments. We're relying on some of those survey instruments. We're utilizing them, but they're becoming a helpful tool as we continue to think about really underlying revenues and expenses being more of a determinant for provider compensation along the way.
And Bruce, just before you jump in here, I would remind the folks on the webinar, if you've got questions about any of these comments or topics, feel free to put those in the chat and we'll do our best to integrate those into our comments. Bruce, what do you see from the health system's response? And you might also kind of, as part of that, flavor into the conversation of what are physicians really looking for? I mean, what's going to help physicians be empowered and feel like these models are working for them as well and be invested in them?
I think I'd start by saying that it's a little bit like Back to the Future, back to Marcus Welby, if you will. This direct primary care model, I think, has got some traction, Kurt. It's very popular with physicians because it gets them off the production hamster wheel, and with apologies to the physicians who are on the call right now, and allows physicians to spend more time with their patients. We won't name on this call some of the large health systems that have rolled out now a direct primary care model, but I think it's going to have some traction because in no small part for the physician, it gives them more time to spend with their patient. And from a revenue standpoint, the so-called monthly subscription fee gives you a dedicated revenue stream. There's no deductibles or copays for the patients. So for a lot of reasons, I think that's going to have traction, as well as the concept of employer direct contracting, depending upon the jurisdiction, of course. In some jurisdictions, that's a non-starter because of the broad definition of what constitutes the business of insurance. But I look at a company like Premise Health that's already in 44 states and has 600 wellness centers, and they set up the facilities near the employer, or frequently right on site, tailored to meet the employer's specific needs. So, thanks for the tip to sort of look at this as well from the physician perspective. And there's a couple of ideas that I think are going to have real traction if they haven't already.
No, I appreciate that. I mean, it's clearly the health systems that we talk to and the physicians that we talk to are looking that want to have an integration model as an alternative to the other, models that we talked about with PE or payers are going to be looking at some of these areas and not. You notice that we didn't put employment on the slide. Doesn't mean that physician practice acquisition employment isn't still a model that will be used, and in some cases can still be the right model. But at least I think I'll comment on my own practice from what I'm hearing is that clients are looking for other alternatives, and hospitals are looking for better ways to partner. So I think that the comments you all made are very helpful. Briefly, before we go to kind of the alternative care models and what we're seeing in that, I do want to have you all comment just briefly on kind of the changing of economics. COVID has really disrupted a lot of the practices. We've seen a lot of volume decreases because of the lack of surgeries that could be performed, or patients just not wanting to go in and see their physicians, and even on routine care. And, the effects that might have on the clinical side are pretty significant. But on the economic side, it certainly does change things. And Cordell, if you could comment maybe briefly on what you're seeing in terms of providers that, as they look at compensation models, maybe that are based on productivity, and then that decrease significantly. And on the flip side of that, Anthony, maybe you could talk a little bit about what you're seeing as the impact of COVID on valuations, or is it having an impact on valuations in deals where there's acquisitions or joint ventures? And then Bruce, if you could maybe follow up and talk a little bit about some of where we see this going from some of the new Stark Law proposed changes and the new Medicare physician fee schedule changes. So Cordell, we'll start with you on the economic side.
I'd say a couple things on the COVID-related impact. It's really been all across the board. Depending upon the relative size of the hospital or health system or the medical group itself, the balance sheet of that respective organization has really kind of dictated the type of protections that have been afforded to providers kind of, managing their way through, the associated pandemic. We have seen, large multi-state health systems that have taken, very aggressive protection strategies. They've leveraged the use of the waivers that, I think Bruce mentioned before, and have really, put into place almost like hold harmless type provisions for providers. You contrast that to health systems or hospitals, maybe they're, $500 million or less, and they've just not been able to honestly, afford those types of opportunities to their providers. And so they've taken, alternative forms of, extensions, loans, extensions relative to payback provisions, et cetera, inside of, how they're managing their way through that. Obviously the waivers that have been associated with, the telehealth and, video and telephonic encounters, organizations that got after that quickly, they recovered a lot of lost volume pretty aggressively, and, quite honestly exceeded almost some of the expectations that they maybe had when they initially went into some of the planning. And then just real brief, as we kind of think through all of this on COVID, it is really kind of illuminated the need for a lot of organizations over time to think about compensation in a different way. And, to think about, compensation, getting away from just kind of straight, kind of per unit widget-based opportunities to something that really recognizes the fact that we have a true professional that's, working on behalf of the mission of the organization, and is starting to, value things that are really outside of just that direct billable type of encounter. And so as we kind of think through how do they respond, I think one of the ways in which they respond is for, provider organizations to, again, I think, rise into this call to action, and to think about ways in which they can become more aggressive as they kind of move down this kind of value-oriented continuum. And as part of that, compensation is kind of, top of the list. Why do most care redesigns fail? It's because we don't have the right incentives in place, for those actually bedside delivering for. And so, I think the summary is, I think the COVID stuff's just all across the board. From a comp perspective, certainly, we have this balance between, what is the right volume and how do we balance that with really kind of other population-based outcomes that we need to manage.
So, Anthony, you want to comment a bit on the valuation side? What you're seeing?
Yeah, not to sound like taking a cue from Cordell, but I mean, I think that very similar realities from the valuation side, all over the board. We have requests that span. Hey, we want to not consider the months that COVID was impacted. To we want to do the valuation that really considers the COVID impact and kind of the most recent data. And I think that different philosophies, different approaches. We also would say that when you look at the compensation redesign aspect. I think that there certainly a keen awareness of, productivity models that are impacted. Not that we're expecting to have a pandemic every year, but I think it at least raises that awareness of what the impact is of that. Back on the valuation side, I think that there's just that reality of, when you're considering multiples and discount rates and risk factors, really being aware of what the potential impact of that. And I think there's a tendency to say, well, if I look at the historical picture, then I'll be able to tell what the future is going to look like as well. The reality is there certainly has been this year and some interruption to those common approaches. And so, I think it's an awareness factor. I think it's a redesign consideration. But again, to not to give Cordell too much credit here, but I do think that it is all across the board as to what we're seeing in the industry right now.
Yeah, I certainly think the next 6 to 12 months are going to necessitate changes to how we've been looking at fair market value and what's commercial reasonableness and those sorts of issues for sure. Bruce, thoughts on kind of these economic issues that Anthony and Cordell just talked about in light of some of the new Stark Law changes and the Medicare physician fee schedule changes?
Well, when we were preparing for this seminar, Kurt, I told you how excited I was about the Stark Law changes, and I remember you saying I need to get a life. But truly, CMS's clarifications that they announced in last October are huge. Perhaps particularly the new definition of the word commercially reasonable, which hadn't been defined before, of course. And I wasn't going to do a lot of quotes today, but here I will. An arrangement may be commercially reasonable even if it does not result in profit for one or more of the parties. I think that's going to have a significant impact on hospital-physician integration because it moves us beyond the loss mentality. This essentially walks back part of Toomey that has been read by some commentators to say that if you're losing money on a particular arrangement, it is inherently suspect. I think as well that we would be wise to keep our eyes on the new Medicare physician fee schedule changes. Kurt, it's been 25 years since CMS announced any increases to the core set of E&M codes. A quarter century since they played around with that. But because all this stuff has to be revenue neutral, you've got some opportunities here for wins and losses, depending upon what the physician subspecialty is and depending upon the hospital's compensation structure. It shouldn't be lost on any of the people on the call that physicians who are compensated in an employment model, their RVU values may go up as a result of the new physician fee schedule announced just in August, but the hospital's compensation may go down because of the other revenue neutral aspects of the recent pronouncement. That's really not very fair. And I'll leave it to the lobbyists in Washington, D.C., I guess, to try to make some points with CMS, but stay tuned as we see how the new Medicare physician fee schedule changes impact hospital physician alignment.
So Bruce, I might make a comment there that, in one of our first poll questions, we asked about what are people doing around integration, and over half of the attendees said they're kind of in a wait and see, kind of not really sure what to do yet. And I get that from the integration side. It would seem to me that based on the tinkering or massive changes, depending on how you might look at it, on the physician fee schedule, it would be very wise for hospitals and physicians to sit down and start talking about their comp models now until they're a year into it, realizing that maybe RVUs went up and I'm getting paid on RVUs, but it creates a much bigger loss for the health system because the revenue just went down, and that some of the traditional approaches we've been using on RVU-based compensation probably need to be looked at very carefully and modeled out. Would you guys agree that that's a...
Yeah, totally.
Yeah.
at a certain level, I sort of resent the way it's been spun that this is revenue neutral. It's not. Yeah. It's a zero-sum game, and dollars are moving between different buckets, is the truth of the matter.
I want to echo that. For those that are kind of participating, anyone that went through this and the change from 2006 to 2007, when CMS introduced something that was called the budget neutrality factor, if anybody remembers that, that caught a lot of people off guard when implemented in 2007. And they're mid-year and they're wondering, like, why is my comp budget kind of going to the roof here, but yet I don't have any revenue offsets to, kind of pay for it. We're pretty close to that, right? And Bruce is right. While maybe at the CMS level, there's revenue neutrality that's budgeted, it's not necessarily revenue neutral, and it's not comp neutral, depending upon your specialty mix, your revenue mix, inside of various, medical group or inside of a health system. So that really is, kind of a, to your point, Kurt, that's not necessarily a stand pat type of strategy. There does require some active engagement at this point on it.
Well, and then you layer on top of that the price transparency requirements that are coming down from Medicare, and needing to publish your pricing and your fee schedules on top of all of this, and it becomes an interesting and new day for hospital physician compensation. I'd be a bit remiss if I didn't put in a bit of a shameless plug for the evaluation around these models like the group practice subsidiary model, which are really intended to remove that tug of war between hospitals and physicians around compensation structures, and really allow physicians to be rewarded for their efficiencies, their productivities, their innovative ways to practice, but yet still have a very close affiliation with a health system. So, I think we're going to see more examples like that of different types of payment structures that are going to have to be put in place that aren't just based on, churning patients or churning RVUs. Well, let me jump to the next section here, and we've got just a time check. We've got about 8 minutes left, so we'll probably be pretty light on this topic, because I do want to allow a couple minutes for each of you to give some final thoughts. But the next topic is care models, and I'll let you guys decide who wants to take the lead, and we don't need all three. If you don't want to jump in, we'll give just a couple minutes to this slide in total. But, what are you seeing in terms of impacts of care models because of COVID, and also kind of where you think we're headed, over the next 12 to 18 months? And I know that's a pretty broad question, but and we've got some examples up here of some topics, and feel free to touch on any of those or anything that's not on the list.
Yeah, I mean, I'll start the conversation, Kurt. This is Anthony. So, I don't think any of us can not see the impact associated with telehealth. I mean, I think the whole telemedicine aspect has, and I think this is probably one of the most, outside of the new normal, this is probably the most quoted phrase, which is, telemedicine has advanced 10 years because of COVID. A lot of things that we heard from providers, we heard from health systems, even heard from CMS as to why this couldn't work from a structural or infrastructure reimbursement perspective, is now in place in a very short period of time. We're certainly seeing that impact. I think as a result, and to go back to some comments that Bruce made earlier about the direct primary care model and some of the minute clinics and some of the other structures that we're seeing continuing to expand, I think you're also, it makes that transition a little easier. So, I think that there's, while there's not a need for brick and mortar, I also would say that, we have several clients that are continuing to build and expand in that format, and for multiple reasons. And certainly that whole outpatient arena, the transitional approaches. And then also kind of a final comment is just, when you look at what is coming down the pike as it relates to direct contracting and some of the abilities and the insurers to go direct and to play in that market a little differently than what we've seen hospitals traditionally work with their payers on these solutions on is also, just care models that I certainly think are transitioning and certainly having a pretty big impact on the industry right now.
Hey, Kurt, the way telemedicine is the 1, 2, 3, and 4 issue here, isn't it? Forrester Research estimates that there will be 1 billion telehealth visits in 2020. 1 billion. I want to take Anthony's comments a little bit in a different direction. I expect to see hospitals and physicians and hospital-physician joint venture arrangements dramatically investing in digital healthcare companies because they will want to control the way the data is collected. Everything from companies that specialize in optimizing the provision of care at the point of entry, like the ED, or urgent care in the home. An example there would be what MultiCare is doing with Dispatch Health, or from a population health management perspective, the way we've seen Mayo Clinic and Helix pair up to do DNA testing. So that's where I see telemedicine playing out, is that hospitals and physicians are going to be wanting to get into the game in a very big way, and not just as the users of the product.
Yeah. I think the only thing that I'd maybe piggyback on is, and I'll maybe take this, very granular to the primary care level. At the core of this and getting to, patients that are attributed to a health system, to a practice, to an individual doctor, RBRVS, and, fee-for-service orientation and face-to-face encounters and payment, that in and of itself is just, it's not adequate to drive the type of care model changes that, the CMS Innovation Center is trying to drive through primary care first, through direct primary care strategies. And so when I think of care model, I think of, primary care being responsible for a panel of patients and having all of these tools, having the office, having telehealth, having the ability to just do, texting and MyChart type of encounters. And what we really want to have is we want to have a mechanism in place that really that primary care physician has all of these tools to be able to help navigate the healthcare needs of an individual. And for far too long, the system was set up to just bring that patient into the office. Let's have the bricks and mortar. Let's have the 3 exam rooms per doctor. Let's talk about these other things that are out there, but let's not really put the right funds flow in place to really embellish and make those work for the patients. And that is just a frontier that if you go to the primary care physician, the best part about what I just walked through, primary care physician is going to tell you, I spend more time doing asynchronous activity on behalf of my patients. I'm doing more work on my couch. At the end of the night, I'm looking at my day starting at 6 a.m. to try to figure out, all the things that I need to do to meet the population-based needs of my panel. But yet, I'm only reimbursed for the things that I directly see inside the office. Those things they're just incompatible and needs to change.
Well, Cordell, that's a great segue to our final topic, which we don't have a lot of time for yet. So I've asked maybe 30, 45 seconds for each of you just to jump in. Now I am sounding like Chris Wallace. Just to comment on some final thoughts in terms of what you think is going to make these strategies successful going forward. And Cordell, since you were on that topic, why don't you start?
Yeah, I think it kind of comes down to we've built and we've acquired a lot of the parts to the puzzle that we really need. And as a set of mostly providers that are on this call, whether it be in a medical group, whether it be in a hospital, or whether it be in a health system, it's really about now, how do we put it all together? How do we optimize it? How do we develop a set of funds flows that really, support a better way of doing it than what we've been able to, than how we've had to do it in the past. I think the COVID thing that, the 10-year acceleration in 6 months is a great point. And, my call to action really, as we talk about this every day, is, don't squander the opportunity. I think the opportunity is in front of you, and there is an optimization opportunity, whether it be through the structure of how you organize, the group, the payment arrangements in terms of how you, remunerate for some of the associated activity. And, culturally, the types of decision making and kind of voice that you provide to integrated medical groups. It's in front of us, and I just think it's, let's just not squander the opportunity.
Anthony?
Yeah, I think continuing to keep the physician as a partner. We hear a lot about not just wanting to make a transaction, but actually build that alignment. And I think frequently we lose sight of where that physician overall involvement is in overall strategy and decision making. And you've got it up on your slide, Kurt. But I think that's a simple bullet and yet a hard consideration at times, because we think we've set up the medical group and we finally got it to the point that we can make no exceptions to policies and things like that. And yet certainly physicians' contributions to that are important. And again, I think some have done that better than others, but I think it's an area certainly we've got to be aware of.
Bruce, final comments.
I'm going to focus on that same bullet point, Kurt, with this kind of an angle. The novel coronavirus is just horrible. And we've spent some time today talking about how CMS has reacted, how it's impacted the evaluation protocols and so forth. I want to say that there might be a silver lining, and this is it. In my professional career of representing both hospitals and physicians, I don't know if I've ever seen hospitals and physicians working better together than they have in the last 6 months or so. A call to action, right? That hospitals and physicians have responded to this horrible pandemic in a way that has them working together like they always should have been. And I think your chart here saying that physician involvement in strategy and decision-making is spot on. And so maybe we take the example of how well folks are working together right now in response to the pandemic and say, and why not have that be the same model for thinking through strategically about hospital-physician alignment?
Well, great. Well, here's our contact information if any of you have follow-up questions. I want to thank everyone for joining us today, and we're ending 2 minutes late, so apologies for that. But reminder that our next session is next Thursday on virtual health, and we'll see if the experts agree with some of the comments today on telehealth. The program is CLE accredited, so feel free to click on that icon at the bottom to get your certificate of attendance. It'll be sent to you along with the recording. And again, please be sure to fill out the survey and tell us what topics you'd like to get more in depth on or see in the future. And we hope to see you again. Thank you, everyone.
Thank you, Kurt.
Thank you.